In this video, we will discuss how the anatomy of the lumbar spine and abdominal wall relates to their function and their clinical significance. We will start with the bones and ligaments, then move on to the muscles, which will be discussed in order from deep to superficial and organized by movement. In the lumbar region, there are 4 movements: flexion, extension, lateral flexion, and rotation. Finally, we will look at the nerve and blood supply. The lumbar spine is made up of 5 lumbar vertebrae. Here we can see the first, second, third, fourth, and fifth lumbar vertebrae. In this particular model, there is an additional vertebra here that is actually a sacral vertebra, but because it did not fuse as part of the sacrum during development, it is lumbarized. This can occur in some individuals and means that this particular individual functionally has 6 lumbar vertebrae. The lumbar spine has a natural lordotic curve to it, and together with the curves of the rest of the vertebral column, it helps to absorb and distribute load in the spine. The lumbar spine supports most of the weight of the upper body, stabilizes the core, and like the rest of the spine, houses and protects the spinal cord and nerve roots. If we look closer at each vertebra, we can see a few distinguishing features of lumbar vertebrae. They have larger vertebral bodies and are the largest vertebrae in the body, reflecting its function as load-supporting structures for the rest of the upper body. They have short and thick spinous processes that stick straight out rather than at an angle. The articular facets are also vertical. 4 different movements occur in the lumbar spine: flexion, extension, lateral flexion, and rotation. 2 types of joints exist between each lumbar vertebra. The first and primary joint is the intervertebral disc joint between the bodies of each vertebra, where an intervertebral disc sits. This disc is a fibrocartilaginous structure that, in addition to connecting the vertebrae, also acts to absorb shock, distribute load, and allow flexibility. Disc herniations are common low back conditions. The nucleus pulposus, which is the gel-like center of the disc, protrudes through the annulus fibrosus, which is the surrounding ring of collagen fibers. Sometimes this causes the individual pain, but sometimes it is completely asymptomatic. Most disc herniations occur at L4-L5 or L5-S1. The second type of joint is the zygapophyseal joint, or the facet joint. These are articulations between the superior and inferior articular processes on each side of each vertebra. They are responsible for guiding movement and do not bear any weight. However, in the lumbar spine, they are oriented vertically and as such do not allow as much rotational movement as compared to other regions in the spine. On the anterior surface of the vertebral bodies is the anterior longitudinal ligament. This ligament starts at the base of the skull and runs down to the sacrum. It reinforces the intervertebral disc and limits extension of the spine. On the opposite side of the vertebral body is the posterior longitudinal ligament, which runs from the second cervical vertebra down to the sacrum. It is particularly important in reinforcing the intervertebral disc and limits flexion of the spine. Next, the ligamentum flavum is a ligament that connects the laminae of each vertebrae. Unlike the longitudinal ligaments, which are continuous, the ligamentum flavum is actually a series of short ligaments. It also runs from the second cervical vertebra down to the sacrum. Interestingly, the high content of elastin in this ligament gives it flexibility and prevents this ligament from buckling into the spinal canal during extension. It is possible for the ligament to hypertrophy, though, which could then cause spinal stenosis, a narrowing of the spinal canal. Spinal stenosis can also result from other factors, such as tumors or bone spurs. Between the transverse processes on each side of each vertebrae are the intertransverse ligaments. They limit lateral flexion of the spine. The interspinous ligaments connect the spinous processes of each vertebra and limit flexion in the spine. Finally, the supraspinous ligament is a continuous ligament originating from the C7 vertebrae down to the sacrum. It connects the tips of the spinous processes and limits flexion of the spine. The first action we'll look at is lumbar flexion, the action of bending forwards at the lower back. Here we can see it overlaid with the goniometer, showing a normal flexion range of about 60 degrees. Psoas major is not a major flexor of the lumbar spine, but can contribute to this movement when acting bilaterally and when the insertion point is fixed. It originates from T12 to L5 vertebrae and inserts onto the lesser trochanter of the femur. Psoas minor is a weak trunk flexor and is actually absent in 40% of people. It originates from T12 to L1 and inserts onto the pubic bone. The major flexors of the lumbar spine are in the abdominal wall, the internal oblique, external oblique, and rectus abdominis. We will discuss the abdominal wall muscles later. Let's look at the movement again. Moving on to lumbar extension, the action of bending backwards at the lower back. Here we can see it overlaid with the goniometer, showing a normal extension range of around 25 degrees. The quadratus lumborum originates from the iliac crest on either side and inserts into the 12th rib and vertebrae L1 to L5. When it contracts bilaterally, it helps to extend the lumbar spine. We can see here the small interspinalis muscles attaching between the spinous processes throughout the spinal column. They assist in the extension of the lumbar spine but play a bigger role in spinal stability. The multifidus is one of the muscles in the transversospinalis muscle group. It is actually a series of smaller muscles running on either side of the spine. In the lumbar region, it originates from the sacrum, posterior superior iliac spine, and the mammillary processes of the lumbar vertebrae. It then inserts into the spinous processes of the vertebrae above its origin. In addition to extending the lumbar spine, it is an important muscle involved in core stability and strength. If we think of the core as a box, then the multifidae are a key component of the posterior wall of the core. Finally, the erector spinae is a group of 3 muscles that act to extend the spinal column when contracting bilaterally. It is composed of the iliocostalis, longissimus, and spinalis. Spinalis does not play a role in the lumbar spine. Here, the longissimus thoracis originates from a common origin with the iliocostalis on the pelvis, as well as the transverse processes of the lumbar vertebrae. It inserts into the transverse processes of the thoracic vertebrae and ribs 4 to 12. The iliocostalis lumborum originates from the sacrum and iliac crest and inserts into ribs 7 to 12. A low back muscle strain is a common injury that individuals encounter when it comes to mechanical low back pain, and this involves straining one or more of the lumbar extensor muscles and tendons. Very often, the reported mechanism of injury for a low back strain will be through a lifting movement. Let's look at the movement again. The next movement is lumbar lateral flexion, where you bend to either side through the lower back. Here we can see it overlaid with the goniometer, showing a normal lateral flexion range of around 25 degrees. Most of these muscles we have already discussed, as they are also involved in lumbar flexion or extension. All of the psoas major, quadratus lumborum, multifidus, and erector spinae assist in ipsilateral flexion when acting unilaterally. The other major lateral flexors of the lumbar spine are the internal and external obliques in the abdominal wall, which will be discussed later. Let's look at the movement again. Finally, the last movement is lumbar rotation, where you twist to either side through the lower back. Here we can see lumbar rotation, showing a normal range of around 5 degrees. As mentioned before, the structure of the lumbar vertebrae prevents much rotational movement, so when we rotate through the entire torso, most of the movement actually occurs higher up at the thoracic spine. The multifidus assists in contralateral lumbar rotation when acting unilaterally. However, the major rotators are the internal and external obliques in the abdominal wall, which we will discuss next. Let's look at the movement again. There are 4 major muscles that make up the abdominal wall. The deepest layer is the transverse abdominis. It originates from the 7th to 12th costal cartilage, the iliac crest, the inguinal ligament, and the thoracolumbar fascia. It then inserts into the linea alba, the aponeurosis of the internal oblique, and the pubic crest. This muscle has a number of important functions, including maintaining abdominal tension, supporting abdominal contents, increasing intra-abdominal pressure to assist in forceful expiration, coughing, and defecation, and supporting core stability. If we think about the core as a box again, the transverse abdominis forms the front and the sides of this box. Next is the internal oblique muscle, which originates from the thoracolumbar fascia, iliac crest, and inguinal ligament, and then inserts into the lower 4 ribs, linea alba, and the pubic crest. When contracting bilaterally, it functions to flex the trunk forwards. When contracting unilaterally, it laterally flexes and/or rotates the trunk to the ipsilateral side. It also assists in raising intra-abdominal pressure. Anteriorly is the rectus abdominis, also known to most people as the six-pack muscle. It originates from the pubis and pubic symphysis and inserts into the xiphoid process of the sternum and the 5th to 7th costal cartilage. This muscle acts to flex the trunk and assists in increasing intra-abdominal pressure. Finally, most superficially lies the external oblique, which originates from ribs 5 to 12 and inserts into the linea alba, the pubic tubercle, and the iliac crest. When it contracts bilaterally, it helps to flex the trunk forward. When it contracts unilaterally, it laterally flexes the trunk to the ipsilateral side and rotates the trunk to the contralateral side. Notice how the diagonal angle of the fibers in the external oblique run opposite to those of the internal oblique, hence the different rotational directions. It also assists in increasing intra-abdominal pressure. Note that all of these abdominal muscles insert into the linea alba, the fibrous band that runs down the anterior abdominal wall. A condition that is sometimes seen in pregnant and postpartum women, as well as in newborns and even in men, is diastasis recti, where the linea alba stretches and produces a gap between the 2 sides of the rectus abdominis muscle. This can be observable and palpable clinically during muscle contraction. The muscles of the anterior abdominal wall are innervated by multiple nerves, most of which originate from the lumbar plexus. The lumbar plexus is a network of nerves that come from T12 to L4 nerve roots. Note that each nerve root exits below its corresponding vertebra. For example, the L4 nerve root exits below the L4 vertebra. The nerves innervating the anterior abdominal wall include the inferior intercostal nerves, which originate from the thoracic ventral rami of T7 to T12, the subcostal nerve, which originates from the ventral ramus of T12, and the iliohypogastric and ilioinguinal nerves, which originate from the ventral ramus of L1. The subcostal nerve also innervates the quadratus lumborum. The ventral rami of L1 to L4 innervate the quadratus lumborum and psoas major and minor. Lastly, the multifidus and the erector spinae are innervated by the dorsal rami of the spinal nerves as they run down the entire spine. The last thing to look at is a general overview of the vascular supply related to the lumbar region. The posterior abdominal wall and lumbar region is supplied by the left and right lumbar arteries, which branch off the abdominal aorta and pass around the L1 to L4 vertebral bodies. The anterior abdominal wall is supplied by multiple branches coming from various origins, including the internal thoracic artery, the external iliac artery, the femoral artery, and the aorta.